Everything, all the information is there, and it's really useful to organize your activity during the meeting. We move on to the second speaker of the session. It's my pleasure to invite Dr. Ewald Boschitsch from Austria, who is going to talk on the advantage of transdermal estrogens. It's my pleasure.
Good afternoon, ladies and gentlemen, Mr. Chairman. How do I start? While you're watching my disclosures, I would like to thank Andrea for inviting me as the substitute of Paul Piet, who unfortunately cannot come. So I hope I can do his work. All right. So it will be. And it's a great pleasure, of course, to be here and to share with you the advantages of transdermal estrogens. Before I go into the details of the data I would like to share with you is I would like to show you some statements of the guidelines. You can see these major societies which are listed here. All their guidelines has been updated recently, the last 2 years, since 2015. You can see that by the dates when it was published. And what are they? So I will not differentiate between the messages of the statements. I will just tell you in general first, which is also valid, of course, for the oral treatment, that menopause hormone therapy remains the most effective treatment for vasomotor symptoms. I didn't know about Andrea's talk before I prepared this, but until now we have to say that. And for women aged younger than 60 years or within 10 years of menopause onset, the benefit-risk ratio is most favorable for treatment of vasomotor symptoms and for preventing bone loss and fractures in women, at least, who are at elevated risk. Going now into transdermal estrogens, we must say that the non-oral routes of administration may offer potential advantages because they bypass the liver and thereby avoid the first-pass hepatic effect. So the use of transdermal estrogen administration compared with oral preparations may be considered less likely to produce first thrombolic risk of stroke, and risk of coronary heart disease. So this will be the major points I will focus on. Oral micronized progesterone, which is often combined with transdermal estradiol. I will not talk about that. I will leave that to the next speaker, to Nick Panay, because this is his topic, the progestogens, and also the breast issue I will not touch because of that. So this is what we will focus on the next couple of minutes. The transdermal MHD, before I go into the risks, I would tell you a few words on clinical efficacy, because some people think less risk, less efficacy. Is this true? No, it is not true, as you can see here. For instance, in this one of many studies performed on the effect of transdermal estradiol, in this case plus micronized progesterone. This is our data from the KEEPS trial presented not even a week ago in Philadelphia by Nanette Santoro. And you can see in the first, yes, you can see hot flashes, the leading symptom that instantly after starting with therapy, it's just the same effect with transdermal in orange and with, I don't know what happened with the colors here. The transdermals should be orange, and the
you have to indicate by the mouse.
This is the transdermal.
Okay.
You see?
Then,
and this, I don't know what happened. So the colors here, they are good, not on the wall. And the blue is the conjugated equine estrogens. You can see against placebo how effective the transdermal approach is. Same thing with night sweats. Let me see if the mouse works here. Yes, here it is. Here you see the placebo. The orange is the transdermal, and the blue the conjugated estrogens. With irritability, doesn't work that well, neither with oral nor with transdermal administration of estrogens. And in insomnia, you can see the effect is there, but it comes much later. In about the third year or so, it becomes significant. So, looking at the bone now, these are our data. We compared 4 active groups. One group using the gel, which you see here. I don't know about the colors again. Yeah, this is the gel, estradiol gel. Again, all groups against a control group. You see here in the gray bar. The dark blue, this is the patches, and the red is the oral estradiol, and in purple the oral conjugated estrogens. You can see that this is all standard dosage, the 50 microgram patch, for instance, and 1.5 milligram estradiol per day, and so on. What you can see in the upper part of the panel, you see the changes in BMD as a surrogate parameter in the spine or at the spine, and in the lower part you see the BMD changes at the hip. And at the hip you see it's even better visible, but it's all significant differences. So both the oral estradiol and the transdermal estradiol both are superior to the patch and the conjugated estrogens. When you compare the data, so you usually use nowadays the data from the WHI because they are well known and they are most discussed as no other data in the world. So when we do that, we should look at the significant findings in the WHI, and this has been excellently done in the paper of Bob Langer earlier this year. And I would like to quote the most important things on the significant findings. In the adjusted results, significant results were only found in a reduction in total fracture and an increase in venous thromboembolism. When you look at the nominal results, they were significant for benefits in colorectal cancer, in hip fracture and total fracture, and significant for adverse outcomes in coronary heart disease, in stroke, and in venous thromboembolism. So for breast, even the nominal results were not statistically significant. So there was no significant increase in breast cancer in the WHI. So looking at the benefits again, you see all fractures, hip fractures and colorectal cancer were reduced, and the risks, as I said, venous thromboembolism, ischemic stroke and coronary heart disease. So this is what we will focus on in the next couple of minutes. I start with venous thromboembolism, and with the most complicated and most dangerous form, pulmonary embolism. And you can see here the purple bar represents the pulmonary embolism as the most potentially fatal event. 60% of pulmonary embolism accounts for 60% of the potentially fatal events. Stroke also very important from this point of view. Breast cancer, as you can see, or coronary heart disease from this point of view is not relevant. So when we look closer at the venous thromboembolism, I would like to quote some of the IMS recommendations published last year. The key messages on venous thromboembolism and menopause hormone therapy is that the events increase with oral MHT, but this is a very rare event under the age of 60 years. Then later on it increases with age and in the presence of other risk factors, including congenital and acquired thrombophilic disorders. Therefore, it is necessary to do careful assessment of personal and family history of venous thromboembolism. This is very important to do that. If you find a risk, you should do some lab tests, look for APC resistance, for instance. So, oral estrogen therapy is contraindicated, therefore, in women with a personal history of VT. And transdermal estrogen therapy should be the first choice in obese women suffering from climacteric symptoms. So, keeping that in mind, we can go now into the detailed data. And here you see, this is adapted from Alfred Mück, I don't know if he's here. You can see that the risks of venous thromboembolism, the dark black bars, this is the oral estrogens, and the gray bars are the transdermal estradiol. So the risk is always low and is the same as in non-users with transdermal estradiol administration, but it is always significantly higher when you use oral therapy. From 1.4 up to 4.5. Why this difference? 4.5 is very large. This is because they are differently adjusted in the different studies. But the ESTA study, where you have this very high odds ratios of 4.5, they have, of course, done in subgroups very interesting studies, and I will show you two examples. One is the weight, so the BMI has to be considered as a risk factor. When BMI gets higher, the risk we get for venous thromboembolism. So when you have a BMI lower than 25, you have about 5 to 6 times the risk with oral therapy, and you do not have an increased risk compared to non-users with transdermal administration. The same here, when the BMI is between 25 and 30, you see that the risk is elevated. The risk is 2.7 in the non-users, 2.9 odds ratio in the transdermal, but 10 already in the oral estrogen users. And when you have a BMI higher than 30, then you see that the risk is increased about 20-fold of what is seen in a low BMI of a non-user. So this, of course, is very important to consider all the concomitant risk factors and not only one risk factor. Another important situation, mutation risk factors, not so rare. It happens quite often. It's different in different populations in Europe, but goes up to 2% of the populations. And you see there is, they looked at two risk factors mainly. One was the factor V Leiden, and the other one the prothrombin G2021A. These two mutations were looked at, and you see when there is no mutation here in the transdermal estrogen use, the same risk as in non-use, and the 4 times higher risk with oral estrogen. And here, in the, if you have one prothrombotic mutation, like for instance the factor V Leiden, then you see that the risk increases from 4 odds ratio up to 25 or 26. So in another study, the general practice research database in the UK, this is a huge study. I think it's about 6 million people involved in this database, and you see there are several nested case control studies performed in this population. And here again, you see non-use in the first line, past use in the second line, it's about 1. And when you use oral estrogens, then you see a significant increase. It doesn't matter if you use estrogens alone or if you use them with progestogens combined. But when you do it transdermally, you see there is no increase at all, neither with estrogen alone nor with progestogen combined. Looking at stroke next, which is also a thromboembolic event, but on the arterial part of the system. For a long time, also by Renew, also from the General Practitioners Research Database, you see, here it says the population, 6 million patients, which are representative for about 8% of the UK population, aged between 50 and 80 years. And you see again, the oral route means an increase in risk, and the transdermal route does not mean this increase or does not show the increase. Here you see the same thing in the graph. On the left side, the oral therapy, on the right side, the transdermal therapy. And you see estrogen alone, the lighter bars, and the darker bars, estrogen plus progestogen. And you have again, as I did show you before, the increased risk with the oral and no increased risk with the transdermal approach. Another study now, this is a new one, I think it was published last year. You see, this is the French National Health Insurance Database, also a large database which comprises more than 97% of the French population. And here you have also a nested case control study, and you can see the oral side here and the transdermal here. And the dotted line represents the overall odd ratios for current users of oral here, and this line, and here for transdermal. So the overall population, and you see that the risk increases with the dose. So this is important to know. That's another important factor. The dose is all dose according to the dose, the risk goes up or is not as high when you use a low dose, even with the transdermal approach. But the transdermal never crosses the 1, so it's in this case, in stroke, in any case, the better option. Looking at coronary heart disease, you know, coronary heart disease, very important. 51% of the population here in Western countries and in Europe die of coronary heart disease or of stroke or other cardiovascular diseases. And breast cancer, for instance, sometimes this does not work, I don't know. You can see breast cancer, the third from the left, from the center, this is breast cancer, 3%. When you look again at a large study, in this case involving about 700,000 participants, because the Danish, as you might know, are the world champions in doing registry studies, and you can see here that when you use the dermal, they call it, the transdermal estrogen, then you see that the crude and the adjusted risk rates, so the risk ratios, are very low compared to the oral, which you see here and here. But this is no, sorry, this is the vaginal, here and there. So in this case, the effect is not as visible as with venous thromboembolism, but it is interesting to see why this happens. So when you look at this slide, at first sight you might have the impression that as lower the LDL is and as higher the HDL is, as better it is, and you cannot reach that when you use transdermal estradiol. But when you look at newer markers, at more sophisticated markers, then you see, for instance, that the pro-inflammatory HDL is increased with oral, but it is decreased with transdermal administration. CRP, very important as a factor for inflammatory disease, is neutral in transdermal, but will be increased with the oral treatment. The same with the serum amyloid A, which is also an important marker, a so-called acute phase protein. Triglycerides, this is well known for a long time, are increased with oral but are decreased with transdermal estradiol. Factor 7 and so on, and prothrombin. In the end, it turns out in clinical terms that the venous thromboembolism is increased with the oral and it is neutral with the transdermal approach, as I did show you extensively before. And this also is interesting for cardiovascular disease, that systolic blood pressure is increased with the oral and is decreased with the transdermal approach. This is mainly, the reason is mainly a dose-dependent factor. Here, Jim Simon, who also presented very interesting data in Philadelphia, did this last year as a sensitivity analysis, and you can see for the venous and for the arterial system how superior transdermal administration is over oral. Women receiving transdermal estradiol therapy have significantly lower incidences of cardiovascular disease events compared with those receiving oral estradiol therapy. And women receiving transdermal estradiol therapy also incur significantly lower healthcare costs. This is one of the very few studies taking care also of the costs which hormone replacement therapy is able to avoid. So you know this slide probably. I don't know if we still have time. No, so we will, this is not so important in the respect of transdermal, because this is a matter of timing. You see the population in the WHI, and you know that this trial was not intended to prove hormone replacement therapy in the sense we define it, but it was a study done for older people to see the effect of hormone therapy in older women. So I will also not go into this, because this is very interesting, the ELITE trial, where you have the biological plausibility of that, what I just said, for the clinical studies. So let me summarize. Transdermal MHT is effective, is as effective as oral regarding the treatment of vasomotor symptoms and the prevention of osteoporosis and fractures. Transdermal estradiol administration may offer potential advantages by avoiding the first liver passage. It does not increase the risk of venous thromboembolism. It does not increase the risk of stroke. It may be used in women with a personal history of VTE when oral estrogen therapy is contraindicated. So you still can treat women who have had a thromboembolic event, but never use transdermal therapy. Women with prothrombotic mutations or high body mass index should avoid oral estrogens. And transdermal estrogen therapy should be the first choice in obese women suffering from climacteric symptoms. With this, one more, transdermal administration may reduce the risk of coronary heart disease. I didn't go into that. Thank you for your attention.
Thank you very much, Ewald, for your very interesting presentation, which is now open for discussion. We have, unfortunately, we have only time for one or two short questions. Are there questions from the floor? here, we should use transdermal sheets. You're welcome. And it's now my pleasure to invite Nick Panay to the stage. Panay from the UK. He's going to talk on the body identical hormone therapy, the way forward.
Pedro, thank you very much. Joaquin, very delighted to see that you've joined us. Thank you to the scientific committee for inviting me to address you. Thank you to Andrea Genazzani. So, what are bioidentical hormones? Strictly speaking, these are precise duplicates of the hormones that our bodies naturally produce: estradiol, estriol, estrone, progesterone, DHEA, and testosterone as synthesized by the human ovary and adrenal. But I think there's been a lot of confusion because compounding pharmacies have used the term to market their own unregulated products, which they justified by using multiple serum and saliva hormone levels to assess the precise individual dosage that the woman might need, and then give an individualized prescription. And unfortunately, this is not evidence-based practice. These are examples of bioidentical products, biased, 20% estradiol, 80% estriol, triaced with some estrone as well as estradiol and estriol, and then bespoke preparations where they put in a little bit of testosterone, sometimes DHEA, etc. And these are often delivered in lozenges, very nicely flavored, vanilla, also vaginal preparations, creams, delivered in many different ways. And there seems to be this concept out there that you can squeeze a yam and suddenly progesterone comes out, or squeeze a soybean and estrogen comes out. But in fact, these products have to be chemically converted, yes, from plant products, via a steroid extract called diostrogen. The concern that I have, that of the menopause societies, is that many of these practitioners who peddle the compounded varieties of hormones are not actually menopause trained. And in the USA, they're often promoted by showbiz celebrities. In fact, there has been a huge amount of hype about these products. And I think the reason this has happened is because post-WHI, there developed a knowledge vacuum. Primary care professionals and some gynecologists stopped prescribing hormone therapy, stopped attending meetings. A number of products were withdrawn from the market, and therefore it allowed for these unregulated products making claims which were not evidence-based for effectiveness and safety to proliferate. So this is the poster girl, Suzanne Summers, who claims that she can remain ageless using these compounded varieties of hormones, and others in the spotlight who have purported to the benefits of these preparations include Oprah and Dr. Oz. Mainly in the States, but certainly we're finding that in the UK, a number of these compounding pharmacies are now popping up. The International Menopause Society, in their global consensus statement, are very clear about their position. The use of compounded hormone therapy is not recommended because of lack of regulation, lack of rigorous safety and efficacy testing, lack of batch standardization, and also inadequate purity measures. In the UK at the moment, a number of healthcare professionals are prescribing compounded hormones, and unfortunately the Royal College of Physicians this year actually hosted a bioidentical hormone therapy symposium supported by the compounding pharmacies. These seminars were not attended by recognized menopause specialists from the UK. Concerns regarding efficacy and adverse effects persist in the UK, as they do in the United States and other countries. And the British Menopause Society published a position statement in which the Medical Advisory Council warned about these unregulated preparations that are being prescribed by clinicians who are not recognised menopause specialists and provided from compounding pharmacies. And the debate was, well, how do we bring these compounders under the regulatory radar? Because at the moment, they seem to be avoiding regulation and control. And despite going to the MHRA, which is equivalent of the FDA and the EMEA in the UK, we weren't able to make any progress. But one of the compounding pharmacies was actually reported to the advertising standards, and when they investigated the products and the claims that they were making, they said, I'm sorry, but you cannot say your products are more efficacious, and you cannot say that they are safer based on the information that we've seen and the lack of evidence. And so this compounding pharmacy had to withdraw the claims, and this is the first step, I believe, to achieving some regulation. It is about providing patients with choice, but as you've seen from DT56A, for instance, you can have a phytoestrogenic preparation, which is very evidence-based, but you can have these conventional type hormones which are not under regulation at all. And I would question what the correct terminology is. Bios is the Greek word for life, and really doesn't make any sense in the term bioidentical. So I think it's better to use the term body identical. And this is a term that I came up with and here published in the editorial with Anna Fenton in Climacteric a few years ago, because this tells us what we're trying to say. It's hormones that are the same as the ovaries and adrenals produce in the body. Now, there are regulated varieties of hormones which facilitate the usage of these body-identical hormones. Estradiol patches, for instance, or gels. For progesterone, to protect the endometrium, micronized progesterone can be used, either continuous combined or sequential combined. And if we want to use a combined pill preparation rather than using transdermal and micronized progesterone, at the moment there isn't a combined oral preparation commercially available, although I'll show a slide in a moment that there is something coming along. But the Femoston range, which contains dihydrogesterone, is another option where you have a biosimilar product as opposed to a bioidentical, body-identical product. Dihydrogesterone is the closest synthetic progestin that we have to natural progesterone. But Ewald mentioned the North American Menopause Society meeting. They presented data from the Replenish trial, which was a phase 3 clinical trial of 17-beta estradiol and natural progesterone capsules, which showed sufficient efficacy for them to take this product to the FDA to be licensed. And no doubt they will be seeking a European license for this combined product in the near future. But are there any differences between body-identical physiological hormones and other forms of hormone therapy? In the IMS recommendations from last year, it was stated that the increased risk of breast cancer is primarily associated with the addition of a progestogen to estrogen therapy and related to the duration of usage. But furthermore, in the recommendations, 3 studies suggest that micronized progesterone or dihydrogesterone could be associated with a lower risk than synthetic progestogen. A large European observational study suggested that micronized progesterone or dihydrogesterone used in association with oral or percutaneous estradiol may be associated with a better risk profile for breast cancer than synthetic progestogens. A case control study from France also showed a lower level of risk with progesterone than synthetic progestogens, and a registry study from Finland, and I think they're as prolific as the Danish at doing registry studies, reported no increase in risk with dihydrogesterone after at least 5 years of use, compared to other synthetic progestogens, which were associated with a significant increased risk. And I'd now like to have a look at the data comparing synthetic progestogens and micronized progesterone regarding breast risk. Because in the WHI study, for instance, there was no increase in breast cancer in those women using conjugated equine estrogens alone compared to those using combined therapy. So what was the role of the progestogen used in WHI, which was methoxyprogesterone acetate, on the effect on breast tissue? Well, we know from cancer cell lines in vitro that synthetic androgenic progestins, such as MPA and norethisterone, are associated with more proliferation. Estradiol with natural progesterone appears to have a good balance between apoptosis and proliferation, where the two are equivalent, and then digesterone even seems to favor more apoptosis, as does tibolone. So these are data from the E3N French cohort study, which has been mentioned already. It's a study of over 100,000 school teachers who were asked to fill in questionnaires about their lifestyle and medicinal choices, and then followed up in the cancer registries. And also the Finnish cohort study, again, looking at prescribing and then followed up in cancer registries. And what we can see here is that the risk with estrogen and progesterone does not seem to be any higher than the baseline risk without hormone therapy in the E3N cohort. And this also applies to digesterone in the Finnish cohort, and also digesterone in the E3N French cohort study. So there does seem to be, from these observational studies, a differential effect between those more natural types of progesterone and progestogen compared to the more androgenic synthetic progestogens, where there does seem to be a statistically significant increased risk of breast cancer. Furthermore, the Cecile study was a population-based case control study in France, in which over 1,500 menopausal women were studied, more than 700 breast cancer cases with over 800 controls. Again, information was obtained from interviews regarding hormone therapy usage, and the breast cancer risks were calculated. The risk with estradiol and micronized progesterone was not significantly increased. The odds ratio was 0.8. The risk with synthetic progestogen, if it was progesterone-derived, was 1.57. Not quite statistically significant there, but it was statistically significant in the testosterone-derived progestin users. So again, we're seeing differential effects between natural progesterone and digesterone and other types of synthetic progestogen as far as breast cancer risk is concerned. But what about cardiovascular risk? Are there differential effects from that perspective? Again, we know from WHI that the excess of coronary heart disease risk in the older populations was partly due to an effect of MPA on lipids, insulin resistance, and impaired vascular compliance. So is there less attenuation of the benefits of estrogen with natural progesterone or other progestogens? These are data from the PEPI study, which looked at various different combinations of hormone therapy compared to placebo. And what we can see here is that for conjugated equine estrogens, there was the expected increase in HDL levels, but this increase in HDL was attenuated by the combinations of conjugated equine estrogen and MPA continuous, and conjugated equine estrogens and MPA sequential. This beneficial effect on CEE and HDL, of CEE on HDL, was not significantly attenuated by the combination with micronized progesterone. More data from the E3N French cohort. In this particular analysis, they were looking at newly diagnosed cases of diabetes mellitus. And what they found was that the percutaneous estradiol combined with natural micronized progesterone analysis was associated with a significantly lower risk of new onset diabetes, and this relationship was not mediated by changes in body mass index. So here we have the data for those women using estradiol with micronized progesterone, showing this reduction in new onset diabetes cases compared to the other hormone therapy combinations. And this is probably because of the beneficial effect of estradiol on reducing insulin resistance, which the natural progesterone does not attenuate in any way, and may even potentially enhance. We talked about VTE risk earlier in terms of transdermal hormone therapy. But what about the impact of micronized progesterone in VTE risk? Because is it possible that the excess of VTE was partly modulated by the effect of MPA on coagulation? And is there less impact with micronized progesterone? Well, it has been recognized fairly recently, I would say, that progestogens may modulate the risk conferred by oral estrogen, and this may be because of a pooling effect, a vasodilatory effect, which leads to stasis and potentially increased risk for thrombosis. There was no or a reduced increase in VTE risk in micronized progesterone users, even with oral estradiol administration in the E3N cohort study and also in the ESTER study. This is the ESTER case control study. 271 consecutive VTE cases were studied versus 610 controls. With regards to oral estrogen, there was the expected increased risk of VTE, and this was mirrored by the increased risk in those women using norpregnane-derived progestogens, but those women using micronized progesterone or pregnane derivatives appeared to be protected from the prothrombotic effect even of oral estrogen. So it seems to down-modulate or reduce the risk of thrombosis when you use more natural types of progesterone. But what we need to do is take these data and work towards the ideal study, working out what the ideal menopause hormone therapy regimen will be. Because the timing and dose matters, as well as the regimen. And in WHI, we know that it was the wrong population. It was an elderly, obese, hypertensive population. It was the wrong hormone therapy regimen. MPA we've talked about already. The oral estrogen was prothrombotic, particularly in the older age groups. And the dose, 0.625 milligrams of conjugated estrogens, was too high for the age group. Now, sadly, these data did not emerge until 5 years after the initial announcement of the WHI data, when initially we were told there was no difference in risk in terms of age stratification, but we now know that the excess coronary heart disease risk was very much within the 70 to 79 population, but with a trend towards reduction in risk in the 60 to 69 and 50 to 59 cohorts. And even in this study, which is now universally not acknowledged as being a poor design, despite that, the recent publication of the 18-year cumulative follow-up data showed that there was no association with excess mortality from cardiovascular or cancer. So even in this worst-case scenario, no excess risk of mortality. So going forwards, what we need to do is design studies that are looking at use of hormone therapy within the window of opportunity and using better types of preparations. We have some pilot data. For instance, the KEEP study was mentioned earlier, a study of just over 700 healthy postmenopausal women, aged 42 to 59. These women were less than 3 years postmenopause and studied for 4 years. And the combination studied were conjugated equine estrogens or transdermal estradiol 50 micrograms or placebo with 12 days of micronized oral progesterone. Because the study was small, they could only look at surrogate measures such as carotid artery intermediate thickness and coronary calcium scores. Now, because this was a relatively healthy population and the numbers were small, it was not possible to show separation in terms of the impact on carotid intermedia thickness between the oral conjugated estrogens, transdermal estradiol, and placebo arms. But in a larger study, potentially you would see separation, and certainly there was no excess risk. And there were no serious adverse events seen, no excess events compared to placebo. But a study that I think does form the basis for a very good pilot study is the ELITE trial, which was designed by Howard Hodis in California, of just over 640 postmenopausal women studied for 5 years. These women were either less than 6 years or more than 10 years after the final menstrual period. And the women were randomized to estradiol 1 milligram or placebo with vaginal progesterone gel 4%. Again, metabolically a better type of progestogen. Again, surrogate marker was looked at, which was the ultrasound carotid intermedia thickness, which was studied 6 monthly. And the study found that there was significant reduction in the carotid intermedia thickness progression of hormone therapy users in the early group, but not in the later group. Hence this window of opportunity hypothesis. So we can see here the progression of carotid intermedia thickness, no difference between the curves in the late postmenopause groups between placebo and active treatment, but you can see here this reduced increase in carotid intermedia thickness in the younger group, in those women using estradiol. And the window of opportunity now is being very much supported not only by the International Menopause Society, but we've seen the data from WHI, from the NICE guidelines in the UK, Cochrane meta-analyses, and in fact all society guidelines now, including the NAMS guidelines, are very much singing from the same hymn sheet. So these pilot studies have good and limited aspects of design. The good aspects are that they're in early menopause, they're looking at more physiological doses and types of estradiol, transdermal estradiol, lower doses for older age groups, and natural oral or vaginal progesterone. The limitations of the design are these are small populations, less than 1,000 in each study, limited duration of less than 5 years, and looking at surrogate outcome measures such as the intermediate thickness and coronary calcium scores. I've been going on for years that we really do need the definitive study which will blow WHI completely out of the water using the right preparation for the right woman for the right indication. This study would be very expensive and I think has to be done globally, perhaps coordinated even by the WHO and perhaps contributed to by governments all around the world. But I still think that we need to do it because even though I come to these meetings and I'm usually preaching to the converted and people believe that hormone therapy may have a protective effect, most of the cardiologists out there still don't believe it. And I think that we do need the definitive study going forwards. So ladies and gentlemen, I think the benefits of body-identical menopause hormone therapy can be achieved without resorting to unregulated compounded bioidentical hormones. Keeps and ELITE have demonstrated that the benefits of hormone therapy can be achieved with no adverse effects on surrogate markers. Given the current evidence, body-identical and body-similar hormone therapy regimens appear to optimize the benefit-risk ratio, but we do need data from large RCTs on hard endpoints, cardiovascular and breast endpoints, from studies that are performed in the window of opportunity to confirm the impact of these body-identical regimens. And with that, I'd like to thank you for listening and an invitation to join us in Vancouver, June 6th to 9th next year. I'm the chair of the Scientific Program Committee, and I invite you all to come to what I think will be a very exciting meeting. Ladies and gentlemen,
Thank you very much, Nick, and especially for a converted. Listening to speak loud and clear about bioidenticals is really very nice for those especially. And we are going to take some questions from the floor. Perhaps it's time to repeat very clearly that we can do the same thing that they claim to do with the bioidenticals, with what we have available at the pharmacy.
Yes, I think it's very clear that there's a lot of confusion amongst the public out there about the differences between the compounded and the regulated varieties. But once I get the woman in my clinic and we have a discussion about what these differences are, they feel very comfortable to use the regulated varieties. They say, well, it's the best of both worlds. I can have bioidentical hormones and I can have a regulated variety of bioidentical hormones. What they want to know is that what we're putting back is very similar to what their ovary is used to produce. Again, you may argue, well, do they know that this is the right thing to do? Do they have the evidence for that? Or is it just something that they've heard from their friends? Well, I think there is an element of that. But again, it's all about education of health professionals and education of the public. And that's where we have to work very hard.
Thank you. So, question? There's one there. Please stand up and look at the microphone.
Thank you. It's an excellent presentation. And I generally make a point when I talk to women saying that you're not a soybean or a cloverleaf, so you need a bioidentical hormone for human females and you're not a yam either. So, but I have a big problem with the transdermal hormones, with the application of it, because the gels take forever to dry and about 20% of my patients are allergic to the patches. Do you know if there's anything on the horizon?
Well, I don't know about 20 minutes. I mean, I just tell them to spread it more thinly and it dries more quickly. Sometimes I just put it onto one sort of patch and don't spread it widely. But there are different types of gel. There's a Sandrina gel sachets rather than the pump, which is lower volume. As far as the patches are concerned, it's well recognized that the dot matrix patches are probably the best patches out there because they're small, hypoallergenic, and they really don't cause skin irritation except for a very minor proportion of women. But I also take the message that you give me, which is we need an even wider range of preparations. For instance, I just came from the NAMS meeting in the States where they have a spray, estrogen, transdermal, that can be used. And I have also seen in development sublingual preparations where women can have the familiarity of putting something in their mouth, but it's still delivered into the circulation, avoiding first-pass metabolic effects. And I would, again, use this opportunity to appeal to our pharma industry colleagues to reinvigorate their research and development programs so that we can have some increased choice and preparations to truly individualize treatment, to find something for everyone.
The availability of the lozenges kind of application is an attraction of the compounding pharmacies that we don't like very much.
Yeah, the sublingual I was referring to is a tab that melts on the tongue rather than a lozenge. The delivery is very efficient. We also had the nasal spray, of course, the Aerodiol, which we lost. And for that, for some of my women, they found that a very useful option.
I have only time for a very short question.
Yeah, the leaflet of the hormones.
Please speak to the microphone.
Yeah, the leaflet of the hormones, depending, probably varies in countries, but they are very frightening. And I think that's one of the big reason why people will compound it, so that because it says things completely different than what we see here. It says that it causes cancer, it causes that, and the patient is afraid.
Thank you very much, because that is another one of the issues that we get onto our soapbox and we complain about. We have such encouraging data now. We need more data, because if we're going to change the leaflets, then we need to convince the regulators of what we're already convinced about, that these preparations are essentially safe. And what really upsets me the most is when you see the same warnings on the leaflets for vaginal estrogen preparations, which don't get systemically absorbed, and yet they're still talking about stroke and VTE risk and breast cancer and all these things, which is absolutely ridiculous. So I agree with you entirely that that is the next thing that we need to take on, present the new data that we have to the regulators, and if they need more studies, then we need to get those studies funded.
Again, thank you. Another question to call my good friend Martin Birkhaeuser, who is going to speak about estrogens after menopause, 10 years maybe.
Thank you. Ladies and gentlemen, Mr. Chairman, Mr. President, first of all, I would like to thank everybody to invite me to this beautiful city, a little agitated these days, but still beautiful. My subject for today is estrogens after menopause, 10 years, maybe not enough. In other words, are we allowed to continue to give estrogens after 10 years, after beginning? I will start with a typical example. A patient of mine, 78 years, when I've seen her in 2002, she was in excellent general health, worked about 50-70%, still as an architect. She was still suffering from severe possible symptoms, but these have been fully controlled by twice half a patch of 25. It was the estrogen patch. In October 2003, her GP stops MHT, explained to the patient that it is criminal to continue HRT because of the dangers. In January 2004, as expected, the patient came to see me again, suffering again from severe vasomotor symptoms. She felt years older and she had to stop her work. Decision, we started again with the same schema of patches. And in April 2004, then she was at the age of 80, she was happy, had no hot flushes anymore, good quality of life, and she worked again in her beloved profession of architecture. She was a fan of architecture. So that is a typical story we can all see every day. But in 2002 or 3, people like this one declared hormones are a disaster, and they pretended that nature has to be made greater again, back to nature. But the basis they put their declarations on has been extremely weak. You see here the results of the first study published with the data of the Women's Health Initiative study. There are only two, it's not really working now, it's better. There are only two items being significant: an increased risk of VTE and a decreased risk of total fracture, benefit and harm. All other items have been non-significant, including cardiovascular diseases, stroke and breast cancer. Nevertheless, the lay media specialist said there was a danger for increased breast cancer, increased deaths and increased heart attacks. What are the facts if we look at it today? First of all, if I'm coming to my subject, we have to realize that the incidence of hot flushes is still high at the age of 80. About 25% of all women aged 65 have still hot flushes. VMS may last far into the ages of 80 to 90 years. There was a study showing that women aged 85 years, in this group we still have about 16% suffering from hot flushes, and 10% have been very or moderately distressed by these hot flushes. And astonishing, so a Swedish study, in this age group of women of 85, 65% were still using MHT. So, of course, the indication for prescribing MHT at this high age is persisting symptoms. I cannot really see another indication, but it's an important one. And as you know from older study, here a study from Heidi Nelson, estrogens, oral and transdermal equally, are highly efficient in treating these vasomotor symptoms, as you know well. For treating symptoms, it doesn't matter if you take oral transdermal. For the side effects, it does, as we see later. And then we know too from old studies like this one from Wiklund, that women taking HRT have a better quality of life if the indication of HRT is symptomatic, climacteric symptoms. You see here the score in women without HRT. It is a low score quality of life, and women using HRT have the same score as normal healthy women before menopause, meaning quality of life is maintained. There is another potential benefit that wouldn't be an indication to continue HRT in this age group, more than 10 years after the beginning, but it might be a potential benefit, and that is a decrease of fracture risk. If you stop HRT, data coming from the Boschitsch study, then you have a significantly reduced survival time and a higher fracture rate than if you are continuing HRT. So considering bone, you're better off if you continue. The opposite has been shown in the States, the data coming from Southern California. If you look at the women who stopped HRT after 2002, panicked by the results, then you have a high amount of additional avoidable fractures. In Southern California, the increase of fracture corresponded to 43,000 avoidable fractures per year. That's a very high amount of fractures. So you have two reasons that don't speak against continuing HRT. In contrast, they are in favor of continuing HRT. And then we have some studies confirming it too. We have the meta-analysis from Torgerson showing that the risk of fractures is significantly decreased in all the women continuing HRT. We have the Coley study done in 9,700 women. It was a prospective cohort study, and these women had to be over 65 years. In these elderly women, the risk for fractures, non-spinal fractures, decreased significantly too. And then we have the Swedish hip fracture study, where HRT users have compared to non-users. If you look at the current users, the risk has been significantly decreased, highly significant, this study. And the women included went up to 86 years. So all these factors speak in favor of an additional benefit if you continue HRT. But of course, we have the potential risks. And here, our data are a bit scarce. We can speculate, of course. If you look at the old Framingham study data, you see that in each age group, women being premenopausal having normal E2 levels have a significantly lower risk for CVD deaths than women being already postmenopausal having low estradiol levels. I think it is not completely wrong to continue this principle up to higher age groups. Then we have the Hearst study. The Hearst study has been dismissed when it has been published because people wanted a decrease of the risk. But in fact, it's quite helpful for our all of today. If you look at the Hearst study, you see that there is no increased risk in elderly women taking HRT. And that was what Nick would call the wrong principle, therapeutic principle. It was conjugate estrus, orally given, and MPA. Nevertheless, they had no increased risk. Speaks in favor of our idea that we could continue HRT after 10 years duration. But you have another study being in favor of the same conclusion, that is the Nurses' Health study. Again, the wrong substances, but at least the result is better than expected. If you look at the younger age group, we have the benefit, the study people wanted to see. But if you go to the women older than 60 years, up to 74, 5 years, then you see no harm. Okay, so that would mean if you continue after 10 years HRT, we are not in front of an increased harm. Stroke. What about stroke potential risk too? We know that age is, together with obesity, the highest risk factor. That is confirmed by the Nurses' Health study and by the from general population. If you go to the Women's Health Initiative, we have seen the results just now. The total population has an increased stroke risk. but that was the wrong population, again citing Nick. If you go to the good population, the lowest, the first tertile of the total population analyzed by the Framingham stroke risk, meaning if you look only at the healthy women, you have no increased stroke risk. And that is not cited enough. It's well hidden in a paper from Hendricks. Nobody knows about it. And the same principle that has been shown just before by both speakers is important for our question to the elderly patient. Transdermal HRT has a lower risk than peroral HRT. So, if you go back to our population, 10 years HRT should be continued. If you continue with transdermal E2, we should be safe. What about the DVT risk? Again, the same. I don't have to come back to the principles. Age is an important factor. And again, the risk is high with oral E2, but is low with transdermal E2. Conclusion clear. If we go to elderly patients even more, we need transdermal approach. More difficult, what do we know about potential breast cancer risk? We don't have any data coming from RCTs going up to 20 years. Doesn't exist. But you have Nurses' Health Study, an excellent observational study. If you go up to 19 years of HRT use, you have still no significantly increased risk. It starts to be significant after 20 years of use. And you have to know it was again the wrong combination. It was CE and MPA, and it was quite a high dosage for an elderly population. But nevertheless, the risk didn't decrease significantly. So we can, or we dare to speculate that the risk will not increase if you continue after 10 years of HRT, up to 20 years of total duration. Mortality. We know that, these data coming from the Nurses' Health Study again, that in overactualized women, there is no association with increased survival. And if we turn it all the way around, if we have high or normal E2 levels, we have no increased risk to die early. And we have a confirmation by the US again. They had again a look at what happened to women who stopped HRT after Women's Health Initiative, and again they had a highly increased risk of mortality. They came to a calculation, Philip Sarah did a calculation of an estimated 58,000 avoidable deaths. That means if you continue E2, you should not see these excess death rates. Let us come to the conclusions. We have seen that the medium duration of heart flushes considerably exceeds the time frame that is generally accepted in clinical practice. If you ask your colleagues not so involved in menopause, they think after age of 70, VMS that is finished, but that's wrong. And we know from all societies has been confirmed that MHT remains the most effective therapy for vasomotor symptoms and urogenital atrophy. Why should that change after the age of 65 or 70? No reason. All societies came to the same conclusion and edited nearly identical statements. Benefits are most likely to outweigh the risks for symptomatic women who initiate HRT when aged younger than 60 years or within 10 years of menopause onset. That's the classical statement. The second classical statement is that data show that the use of HRT is safe for at least 5 years in healthy women initiating treatment before the age of 60. But then comes the new addition to these statements, again by all societies. There are no reasons to place mandatory limitations on the duration of MHT. So that means if you have an indication and if a healthy patient, not coming from the wrong population, as you've identified it just now, you're allowed to continue. On the other hand, what are the dangers of withholding MHT to healthy women needing continuation after more than 10 years, meaning having a clear indication? You risk a relapse of severe vasomotor symptoms, and we know from other studies that implies a higher cardiovascular risk, that implies a higher risk for depression, and that implies a high risk for osteoporosis. The data are here. Then we will see a relapse of the appearance of urogenital problems. You will see a compromised sex life, a lower quality of life, and we have a lot speaking in favor of this too, a higher risk for cognitive decline. What can be the practical recommendations? First of all, we have to state, based on the evidence available, it can be forwarded that in healthy elderly women, continuation of MHT for more than 10 years is safe. The benefits outweigh the risks. Then we know that continuation of MHT has a positive effect on Climacteric syndrome, the main indication among bone. It has no negative effect on the cardiovascular system, but there we have to use transdermal estradiol, and we have to use the bioidentical progesterone or diprogesterone, and not one of the synthetic progesterones. And we know that the effect of MHT on stroke risk depends on age, on the dose, on the way of administration. If you look at elderly women, again, you have to use, for that reason, low-dose transdermal E2 and the same 2 types of progesterones. And the third point, the effect of MHT on VTE depends on age, on the dose, and on the way of administration. Again, the same conclusion. So if you put all together, if you use E2 transdermally at a low dose, the example of my patient showed you that you may use even a lower dose than the lowest patch we have, then you should be safe. What about breast cancer? I think we can dare to say that ESAs alone have no negative impact on breast cancer risk up to 19 years, but it's based on one observational study. We don't have more data. We have no data available in women where the average age has been over 70 using a low-dose transdermal MHT for more than 20 years. That is simply missing. And that we have to inform the patient. But we can tell her what we know about the self-study. And again, if a progesterone is added, it is wrong to think, as some emergencies still do, that there is a plus effect. Again, we have to use progesterone, minus progesterone, or diprogesterone. So the conclusion, you see it here. There is no reason to stop HRT after these 10 years, but the decision on continuation has to be based on a woman's individual risk profile. And then you should use the lowest effective dose, you should give it transdermally, and as you said before, only these 2 substances should be elected. My last slide shows you a citation from Klaus Christiansen. It takes few months to publish wrong data. It takes 10 years to correct it. Even he was too optimistic. Yeah. Now at 15 or more. Thank you for your attention.
Nice presentation, Martin.
Are there some questions from the floor? Yes. Please go to the microphone. David.
Really, I have no question, but it is a pity that Professor Martin Birkhaeuser is not the advisor of all Ministry of Health, according the treatment of menopause. Really, I agree that you are not the advisor of all ministry. And sometimes, do you follow official recommendation in your work? Do you follow?
Well, to be honest, I follow the recommendations of my own menopause society, and I wrote it myself.
Okay. No, but really, all ministry have a group of advisors,
yeah,
and they follow the group of advisors. But inside this group, you or somebody like you is not included, and we follow recommendation like this. You know, this is why I would like to be our advisor.
Okay. Please go to the microphone.
Thank you very much for giving us this talk again after to continue using the HRT after 60 years old. In some countries, we don't have the transdermal estrogen. Do you believe that if she starts estrogen early in her menopause without any complication and she continue with the oral, she is unlikely to have a side effects even if she continue with the same dose she started? Or do we have to have them hysterectomized after 60 years of old, so we can agree on the principle that estrogen oral indefinite for life?
Thank you. That is a very important question, a delicate one. I think we don't have any study about that, but I think if you change from transdermal to oral in your later life, you have again an increased risk for stroke and the increased risk for thromboembolism, most likely. So if you don't have a jail at your disposition, perhaps you can find a solution together with the pharmacist of the next university. I think he should be able to make a gel of a pure estradiol product. That should be possible. Would be much safer.
Okay, wonderful. We are finishing exactly on time, and I think, yeah. Okay, thank you very much for may I ask Andrea and David to come to the table?
Ladies and gentlemen, good afternoon. I ask you to stay and to sit. Michel, thank you very much if you can sit. And Martin also. Lydia, you speak too much. Okay, then ladies and gentlemen, thank you for being here. We have the pleasure to be at the official opening of this conference. And then I would like to give you just a few words and few explanations what we have done and what is the session now. Close to me is Professor Barry and Professor Calaf, who are the chairman of our congress, which they were strongly helping in developing it in Barcelona. I will go. I would like to give you just a few numbers. Can I have my slides? Okay. I'm sorry. If you can go back. Thank you. I would like to give you some numbers. These numbers they were collected just nearly 2 weeks ago because to make the slides and to make the calculation we needed some time. And then I want to tell you that the 5th of October we had 1,300